Hello, everybody. Welcome to week 7. We are almost done. First thing I want to talk about today is the rest of the semester. Uh, so this week we'll cover chapter 13 and 18. I'll kind of get into that real briefly towards the end of this talk. Uh, Next week is going to be a very busy week for you. I do understand that. I will take it into consideration. If you have issues or anything like that, let me know. But there's going to be 3 homework assignments and 3 quizzes. However, it is the anatomy of the body. The text goes into not great detail. That will be your next class, XCT 212, which is cross-sectional pathology. We'll get more into detail of the human body and cross-sectional anatomy at that point in time. But it gives you kind of an overview of what it is. Just make sure you read the book. The quizzes and the homework are not very hard. I designed them that way, so that way they should be pretty cut and dry for you as you move ahead, since there is an extra quiz and homework assignment for next week. But this week, chapter 13 and 18, however, keep in mind, this is going to go fast. The next 2 weeks are going to go very, very quick. Here we are already in Monday of week 7, and it's been great. I've really enjoyed working with you guys. Even though I can't see you, I can still talk to you via email. Apparently, there has been some issues with the quizzes about seeing the questions that you've answered incorrectly. I'm not really sure about that. That might be a glitch on Cobra's side, because I've had to reset some of the quizzes. But you should be able to see the questions you answer incorrectly. I don't have a problem with you answering, if you know the answer to the question, everything like that should be pretty simple, because the final is going to be based off a lot of the quizzes and homework assignments that you've done over the past 8 weeks. So the final should actually be pretty easy for you. I don't make this course hard, as well as I don't make the XCT 212 course hard, because I know this is advanced imaging modalities for some of you. The other was, it's an introductory to like a registry review. So it does get your feet wet with CT and everything. So I'm trying not to overwhelm anybody and things like that. Again, I'm looking for feedback. If you guys let me know if you liked the class, didn't like the class, different things like that. We're going to kind of get into that starting probably next week a little bit. But regarding the wrap up of week 6, we started talking about multi-slice computer tomography. Again, this is something that you've all probably have seen or worked with, because almost every scanner in a hospital or a clinic today is multi-slice. You have anywhere from a 4-slice scanner up to I know there's a 256 slice scanner. I believe there's a 640 slice scanner that Toshiba makes, or Canon, whoever bought them out. Different things like this. Some are good for specific things. Like a 4-slice scanner would be great for CT biopsy. That would work out really well, but you probably wouldn't necessarily want to scan somebody with an active brain bleed with a 4-slice scanner, because it's going to take too long. But with multi-slice scanning, we start talking about volume imaging. Volume imaging is basically like if you take a loaf of bread and you put it all together, and then it will allow you to see the outside of the bread. You can break it open, you can see the inside. It's the same with the human body. The volume imaging, they create a lot of information, but you can see from the principles and the instrumentation, it takes a lot more physics and a lot more instrumentation to deal with multi-slice imaging, because of the amount of information that you get on your raw data. If we've talked about in chapter 12, we talked about CTAs, and how we create that. A CTA is, we isolate a vessel such as the aorta, and we inject the patient with contrast, and we just look at that, but we can grow it out. You might get, say 300-400 images off a CTA from the chest and where to bifurcates right in the pelvic region. However, we do what we call CTA leg runoff. That's where you go basically above the kidneys all the way through the tips of the toes. You might get 1,800 images from a multi-slice scanner at that point in time. So it's going to take a larger computer. It's going to take a lot faster processing speed because you're going to use that. So that's why it's very important to know about multi-slice imaging, because this is today's technology. This is what we use today, and it's really cool. It's really fast. It allows facilities such as Carle to keep their level 1 trauma designation because they're allowed to. Or they have the ability, not allowed to, but they have the ability to scan somebody very fast. Somebody can correct me if I'm wrong via email if you would like, but last I heard they had a 64 slice scanner in their ER. I don't know if they've upgraded to 128 slice or not. That's I haven't been to Carle for quite a while. Those that do clinicals there can correct me if I'm incorrect, and I do apologize if I am. I'm just going off data that I've known in the past. But that allows to do a head CT very fast, keep their stroke designation as a stroke center, and it allows it to do the level 1 trauma center, so they can do a head, a neck, and then a chest, abdomen, pelvis, and see what's wrong with the patient so they can treat them appropriately and very quickly, and then go from there. So read through the multi-slice if you haven't already. Just skim through it. It's a very interesting chapter. Kind of gets into a lot of the historical background as well as the different instrumentation that is required to do multi-slice imaging. Then chapter 12, pretty much we started talking about heart imaging, CTAs, different things like this. These are advanced CTs that you'll see done more in a controlled environment, such as a specific CT suite that is not an emergency room. Now, they do CTAs in the emergency room. If you've heard of a CT or spiral CT of the chest, sometimes it's called, or CT of the chest with contrast for pulmonary embolism. That is a CTA of the pulmonary arteries. It allows you to see the blood clot within the pulmonary arteries so the patient can be treated via medication, greenfield filter, or different treatments that way. But that CTA allows us to isolate specific things. We cannot, it's difficult to isolate veins. We can do it using timing though, with different things. And that's what I kind of want to talk about a little bit regarding chapter 12. And it comes to CTAs, is it's all about timing. You have to know how many seconds it takes from the time you inject the patient in their arm, which will be left or right, really doesn't make a difference, to the time it gets to the heart, and then out the aorta to where then it's perfused out throughout the entire body. There's different timings through each and every one. For an example, if you were going to do a chest or an abdomen pelvis and you wanted to do a non-equilibrium stage liver, which means you can kind of, you would be able to see the different tissues within the liver, there's 2 blood flows to the liver, so you'll be able to see that. You're probably going to wait about 55, 60 seconds and then scan the patient. That's the time from injection. However, if you're going to do a CTA of the aorta, you might only wait 8 seconds. But then that also depends on the patient's cardiac output. So there's a lot of variables when you start talking CTAs and different things like this. This is where the history comes very, very important. Does the patient have a history of high pulse rate? If they do, that 8 seconds that you're going to do that CTA of the aorta may drop down to 6. If the patient has, congestive heart failure or some other cardiac problems, you may have to adjust your timing according to that. Now you can use things like, I know GE calls it smart prep. Everybody's got a different way of looking at it, to where you take one slice through the patient and you look at a specific blood vessel. As soon as it lights up, as we say, or has contrast in it, then you go ahead and scan the patient, and it allows you to scan without guessing your time. I would suggest you use that because it is a great tool. However, there are situations out there where you can put an ROI, which is a region of interest, in like the aorta, let's say, and then when it gets to a specific Hounsfield unit, the scanner will scan itself or start itself. So I don't like that idea. That's just me personally as a CT tech. I would rather be responsible for telling that scanner when to scan, because you never know what's going to happen inside the human body. You really need to take precautions and make sure that you're in control of it. Now, again, that's just my opinion. Somebody that is more versed in a lot of the newer technology scanners, some of the real fast scanners, they may say, no, you don't want to do that. This is exactly what you want to do. And you want to go by their advice. But that's just me. I'm kind of a control freak because that's how I learned X-ray. We needed to control it, and I learned CT the exact same way. So that's kind of kind of went long here a little bit tonight. And again, I apologize for that, but chapter 11 and chapter 12 are very interesting. It really starts getting into the scans that we do today in a clinical setting. Now, next week, or excuse me, this week, I guess it is Monday, we're going to study chapter 13 and 18, okay? 13 gets into a lot of the advanced different technologies of CT, the different scanners, the different things, and we start talking about 3D. Volume imaging, 3D. We can make 3D volumes of bone fractures, make 3D volumes of pretty much anything if you do volume imaging on it. Read through it. Very cool chapter because this is something you will do, especially if you do like a CT of the shoulder that is fractured, maybe the head of the humerus is fractured off, and the physician wants to take the patient to surgery. You will do a 3D image of that. You'll spin it so the doctor can see it. Now, one thing that I want to say about this chapter specifically is we can all see these, and I know I'm going long, but just bear with me. We see all these very cool images that are colored, that show the bone, show the different blood vessels, everything like that. I cannot stress you more, today than any other time, really, that if you see a colored image, it is non-diagnostic. It will not help the radiologist. The radiologist wants to see the grayscale images, whether that be axial, coronal, or sagittal, doesn't really make a difference depending on their protocol. But if you see a colored image, it is non-diagnostic. Now, that doesn't mean it's not going to help. Okay, that's not what that means. If you do the same shoulder injury, it might help the surgeon know, okay, well, here's a comminuted fracture. I have to take this piece and put it here and then put the rod in, maybe with a plate. It will help the surgeon in surgery, and that's what we're there for. So if it is part of your protocol, you want to do it. You want to go ahead and take care of it. And we get into chapter 18, we start talking about QA. The tests we run on a scanner to make sure that it is scanning appropriately according to spatial resolution, the CT numbers, the different speed of the table, different, contrast resolution, different things like that. Read through it. Very important chapter because if you're accredited with the Joint Commission or ACR, you are going to be doing this on almost a daily or every other day basis. So you want to make sure that you have an understanding of how that all works, okay? So read through the chapters, go ahead and take the test and the homework this week. I have went ahead and reset chapter 13 and 18's test or quiz this week, so they should work out. You should be able to see the questions you answered incorrectly with your user response and everything like this. But again, I'm available if you guys have questions. Please don't hesitate to get a hold of me. We'll get you the answers the best I know how. So I really appreciate you guys working with me. If you have any questions, let me know. But I will see you again on Monday next week for one of our final videos together. So have a great evening, and I wish you all the best of luck this week. Have a great night.